Thank you, Ken, and thank you, Smart Colorado, for organizing this conference. I think it's a great opportunity to present some science on the topic of marijuana. And also, I'd like to thank all of you that are attending, taking time for a day to come and listen to information on marijuana. We live in a great state, a beautiful state, and the fall colors are here. This is actually a shot going up Pikes Peak on the Cog Railway. And in addition to being a beautiful state, Colorado has a couple of problems. One, it's a number one substance abuser in marijuana, cocaine, non-medical opioids, and alcohol. So certainly there are difficulties within the state on substance abuse. And in addition, we're one of at least 15 states that have more deaths from drug overdoses than from auto crashes. So substance abuse is a serious issue that we must address. Today, I'll just give you a brief overview of what I want to cover. I would like to talk about marijuana and the unprocessed plant and then extracts, the THC and the cannabinoids that are a part of this plant. Then talk about how the plant and extract materials are used, how they're some of the differences between smoking and edibles, and then really address the question of marijuana as a medicine. Then we'll talk a bit about some effects of marijuana, including some effects on the brain. And if we have time, I'd like to talk a bit about the drug testing industry. Quest Diagnostics has done a survey for 20 years on drug testing results within the United States, and there's some pretty interesting findings that were just published. And I know many of you are going to be seeing repetitive information. Many of you have experience with the plant and with information on it. So for those of you that this is repetitive, I apologize, but we did want to give a basis for the discussions on previous effects of marijuana. So the plant itself is a cannabis. There are a couple of different species, sativa 1, indica. Generally, when we think of marijuana, we think of the stems and the leaves, but the trichomes here are the resin glands on the leaves and buds. Now, if you look at this bud down on the right-hand picture, you can see tiny little glistening pods, which are the resin glands producing the cannabinoids, primarily THC. And that's the most concentrated part of THC on the plant. And then just a description of the plants. The leaves are quite different between sativa and indica. Sativa here, that may be 18, 20 feet tall if it's growing wild. Now, as you saw in the previous picture, when it's being grown in a greenhouse and grown for production of THC, the plant's not allowed to get anything approaching that height. Now, Dr. El Soli, since somewhere in the late 70s, has been tracking the concentrations of THC in cannabis from DEA seizures. As the DEA goes across the country and does a seizure, then it sends the plants down to Dr. El Soli at Ole Miss, and he measures the THC in the plant. So you can see from 80s, and this is really representative of the time prior to this as well. You know, the 60s, 70s, and 80s, or early 80s, were all THC concentrations less than 3% or so. So More recent concentrations, you can see are up around 12%, and this is 2014, but those are the DEA seizures across the country and probably some from foreign countries. That does not represent what we're seeing in Colorado. And the Cannapages are the coupon book for the various cannabis industry companies. You can see here that there's one advertisement for THC at 18.59%, and then we have critical mass here at 26%. Now that's 26% of the dry weight of this plant is THC. That's a lot of THC, folks. That's a heavy dose of marijuana, no matter how you take it. And one thing that is heard frequently about the marijuana industry is that it's natural, therefore it is inherently good. You can see this plant leaf, kind of focus on this one in the center. Looks a bit like indica, but in fact that's castor bean. And there's actually a famous murder case in UK from Georg Markov that was involved in the Soviet spy problem and ended up being killed by a few grains of ricin, which is produced by the castor bean. And then of course we all know the many other plants that are not necessarily good because they're natural. I also know that in California an occasional highway worker will die or get extremely sick from trimming the oleanders in the center of the highway. Now I don't want to spend a lot of time on hemp, so we'll go through a couple of things and eliminate hemp and then the cannabimimetics. But hemp, according to the Agricultural Act of 2014, has to have a THC concentration less than 0.3% dry weight. The federal law, both of the Food, Drug, and Cosmetic Act apply, and the Controlled Substances Act still applies to hemp. So hemp has very little THC in it, but in addition, it has to be controlled by the state. And the site that is growing has to be registered, they have to have approval from the state. Generally, it's a lot better if it's involved with a research institute such as a university. But one important thing is that there's no transport of hemp across state lines. And this was published in the Federal Register just recently. Now to move on to the cannabimimetics. The cannabimimetics have been in the news probably for the last 10 or 12 years based on spice, K2, and there are a whole series of cannabimimetics. And Dr. Huffman of Clemson University was a prolific, I guess I'd call him a phytochemist, because he synthesized probably at least 300 cannabimimetics. Out of these, there are about 35 that actually bind to the receptor in the brain where THC binds. And do you think that these are harmless? A lot of times K2 can be bought over the counter at some market at a service station, or the various markets will handle these cannabimimetics as spice or incense, and there are a whole bunch of other names. The problem is that some of them, not only interacting with the receptor on the brain, are very toxic, and the company producing them doesn't really care about toxicity. They're more interested in profit. And if what happened early on with the DEA, they would try to control one of the various cannabimimetics, and then the companies would just switch to the next one that Dr. Huffman had synthesized, and it was a never-ending problem. So what DEA did was really neat, and they classified these drugs as cannabimimetics if they bind to this receptor in the brain. And there are a couple of receptors, and actually the effect of THC is all about receptors, but I don't want to get into that, into the chemistry of those, but this CB1 receptor is in the brain, there's a CB2 receptor, and some non-CB receptors that do a variety of things in the body. So the DEA thought about this a bit, and if something binds to the CB1 receptor, and through research studies they can tell that, then it is classified as a cannabimimetic and is a Schedule I substance. So that was an important way to start to control the cannabinoids. Now the use of cannabis. Back in the 60s, it generally smoked some use of hashish. And hashish is generally the trichomes that are isolated off of the plant, concentrated, kind of a black tar type of mix, and somewhere around 40% THC. But generally the use of marijuana was by smoking, and as you remember from that previous slide, the THC concentration was quite low, less than 3% in most cases. Today, and actually Gallup did a poll, and if you don't believe Gallup polls, then you can look at SAMHSA, but the Gallup poll found that in 2016 that 13% of US adults are current users. More than 40% have tried marijuana, but 19% of young adults, and I believe that age group was 18 to 25, are currently using. And they're using stronger marijuana, different delivery methods. But here, if you remember any number out of this, remember Colorado at 31% in recent use, 1 month, is using marijuana. National average 19.3%. THC preparations, I guess the important thing here is that there are big differences between inhalation and edibles. Marijuana has to be activated, and if there's an edible, it has to be heated, then the THC is active, it goes into the body, and the body then takes it to the brain and there's an effect. But this takes some time. You digest the food, the THC is transported across into the liver, then goes up to the brain, and the effect is less than smoking, but also much delayed. With smoking, either smoking just the plant material, vaping a liquid that's an extract from the plant, or doing dabs, the THC goes directly to the lungs, into the blood, directly to the brain, and there's an immediate hit that a person feels, and then it's of course transported from the blood into the brain, and depending on the dose, you have an effect. Big difference between tolerant individuals and non-tolerant. In a non-tolerant person, 25 milligrams of THC will cause substantial drug effect and cognitive impairment. So that's not a lot of THC when you're looking at the concentrations that are currently available. And just on smoking, not to get into a big discussion about the carcinogenic effect, but marijuana does contain the same carcinogens and toxins as tobacco. And it may be different because there are fewer cigarettes smoked on a daily basis for marijuana as opposed to most cigarette smokers. But it's definitely a toxic smoke. Causes chronic cough and bronchitis, airway obstruction. A recent study, now I want to point out this is secondhand smoke. This was not a person that was smoking himself. This was side stream smoke or smoke that was coming from someone else. And they eliminated the THC and found that there were just significant cardiovascular effects from the smoke, not from the THC. So the smoke from marijuana is an issue as well. Okay, now I call this the next big tobacco, and look at well, you all know about the preventable deaths from cigarette smoking. Current smoking on the cigarette side has been declining for the last 20 years. And here, this number is 21 out of every 100 adults in 2005. It has reduced to 17 of every 100 adults, so around 16%. But marijuana use is increasing, and it's approaching, well, we saw that number 19% average across the nation of young adults, 31% in Colorado. And so the marijuana use definitely is approaching the level of cigarette smoking across the country, and that is a concern for public health. And this, I just show her as a stoner girl. What I really want to point out is this, the size of this, what they call the rig or the oil rig. And that is full of marijuana smoke from something that she has prepared, put a dab onto a hot plate and pulled the smoke up through this, this glass pipe. And then in particular, look at this. I took this photo myself. I ventured into a rec store. Girl Scout candy. And it's got 10 milligrams of THC in it. It's red berries in a little bottle. If that had 10 milligrams of nicotine, I suspect that there'd be a bit of a public outcry just on the basis of our feeling about tobacco. Vaping is just another way of getting cigarettes or getting smoke into the lungs, either tobacco or marijuana. It turns out that THC is the most common used liquid in the vaping pipes, and so if it's either tobacco or THC in most cases. Here you cannot smell the THC that's being smoked. Hard to tell if something is being smoked. But again, this liquid is heated to around 200 degrees centigrade in the vape in this pipe. And many of the e-liquids contain all kinds of chemicals. So the concern about vaping is the long-term toxicity of many of the substances that are contained in the liquid itself that is vaped. Some of the pipes are burning, batteries are causing the pipes to melt and catch on fire, and so you can see that 48 states have banned sales to minors. Back to the THC. THC itself does not dissolve well in water. It's a hydrocarbon, not soluble in water, and it's got to be activated by heat. And it's THC acid. When you activate it, it becomes just THC. So eating a raw plant has little effect. But baking will activate it, or smoking and vaping, that heats the product enough to activate the THC. And the effect is based on the dose and experience of the user. A person that is, well, I'll just say that there are stories of people that have become so tolerant to THC that they say that they can't get high anymore. So no matter how much THC they take in, they can't get a high. And so if that's the case, then you go back and take that 26.3% THC and see if that helps. CBD is generally taken as a solution. It's dissolved in oil. Again, it's not soluble in water, so it really needs to go into an oil. Can be dropped under the tongue or taken orally. And then dabs and wax and shatter, those are the very concentrated extracts of the plant. And the experienced users can control the amount that they're inhaling by just limiting the amount of smoke taken into the lungs. But that doesn't apply to edibles. If a person takes an edible, then that drug is in their system, and there's not, well, I guess they could purge, but that is the problem that some people have come into the state, they bought a cookie and they've eaten the entire cookie not thinking there was any effect and not realizing the delayed effect of the edibles, and had such a huge dose that they had quite a negative effect. There's a recent paper that where users are saying that dabs are definitely more addictive and create more dependence than other uses of THC. And the important thing there is that dabs are generally about 80% THC. A dab is an extract, and they're very concentrated THC. Now, this device, it's a glass pipe, and this, a glass tube, and it's sealed at the bottom with a little valve, and at the top, a user can stuff it full of marijuana plant material and buds or whatever they want to put in it. And then they throw in a little bit of butane and let it soak for a while to extract the THC. And then you open the valve down here at the bottom, and in most cases it runs through a glass tube down through the top of the table here into a pan that is just catching the liquid as it comes through. difficulty being that butane is extremely flammable, and then if the person lets the butane evaporate, they walk out, they flip off the light switch, it blows up the house. So butane, ethyl alcohol, many of the solvents that are being used to extract the THC to produce wax or dabs are very flammable. And you can go to the web or go to the internet and just search fires from dabs or dabbing, and all kinds of great videos on houses that are burning. And then the extracts are generally kind of a honey-colored, dark honey, brown-colored, but it's very pure THC. And then when the solvent evaporates, then you get various materials of consistency depending on what you have extracted. Here's just a house fire, and the difficulty is that when you look at these pure extracts, many times they're $500 an ounce. And so a person that is using may try to extract their own material, and if they don't know what they're doing, the professionals know what they're doing, the amateurs do not, and there are some subsequent problems. Now, I find this interesting, and this is the correct way and the safe way to do extracts, and the commercial companies in Colorado are sometimes using this. Actually, the apparatus is probably about 6 feet high, and then it's got a control panel. But what they do is take critical point carbon dioxide, which is carbon dioxide that's compressed and heated, and it will extract the THC just like a flammable solvent, but carbon dioxide is not flammable. And so this is actually a very safe way to, if a person's going to extract and they have the money, this is the way to do it. So some companies have moved to this. The side note on this particular product is that if you go to their website, they say that there's a way that you can get essentially pure 99% THC scraped off the side of one of their evaporation columns. So we're always looking for better and more concentrated THC. Okay, the THC is stored in fat tissue in the body, and as it's released from the body, then it's cleared, converted into 11-hydroxy-THC, and I don't want to show any structures, but THC goes to 11-hydroxy-THC, and then it is converted to THC carboxylic acid, which is what ends up in the urine and which is tested in drug testing. But both THC and 11-hydroxy are psychoactive. CBD is it's a cannabinoid, but it's not psychoactive, and it is what's currently being used as Charlotte's Web oil. And again, it is a Schedule I because it is an extract of marijuana. So DEA considers CBD still as a Schedule I substance. And they also have classified CBD as having no currently accepted medical use. And this label accuracy on most of the edible products is rather poor. And Ryan Vandry has done some research out of Johns Hopkins and has talked about the accuracy and the content of various edibles. The thing about Charlotte's Web oil, the controlled studies must be completed with known composition of the drug. And there was a study done here in Colorado, which was basically a review of about 75 cases of parents that brought in children that had been treated with CBD. The only problem is that there was no definition of the concentration that they had been given, of what the material was, what was in that material, but they did have some positive effects and some negative effects from this study. But it was an after-the-fact, just interview process. I don't want anyone to think that someone in Colorado was administering CBD to children as a research study. That is not happening in this comment. Okay, THC and CBD do have effects on the brain. Anticonvulsant effect of THC is on the CB1 receptor, euphoria CB2. CBD, again, as an anticonvulsant, has had a lot of publicity. It's also an analgesic. But the effects of both of these, THC and CBD, are through these binding receptors in the brain, the CB1, CB2, and then there are a whole bunch of other receptors that we don't need to get into here. So there are potential beneficial effects of marijuana, but I want to say medical marijuana is not medications from cannabis. My view is that there are medications in cannabis that should be developed and may be used, but they require the appropriate studies. And DEA just published an 80-page synopsis of information on marijuana in the Federal Register. They retain marijuana as a Schedule I substance, no approved medical use. And if you're interested in the science, it's really a great article because it has all of the background on their consideration on marijuana. So medical marijuana to me is the use of the unprocessed plant. And if you look at medications from cannabis, there is certainly a potential for materials that can be developed as pharmaceuticals. But marijuana is high potential for abuse, and well, you can see those. For a medication to be a medicine, or for a drug to be, for a substance to be a medicine, the drug chemistry must be known and reproducible. You have to have adequate safety studies. You have to prove that it is efficacious with controlled studies. And it must be accepted by the appropriate experts, and the scientific evidence must be widely available. And this statement is from the DEA publication. Marijuana does not meet any of the 5 requirements. Now, we do have medications from cannabis. A cannabis medication, Marinol, has been available in the United States for, I'm guessing, at least 25 years. For nausea, for anorexic conditions, especially following a chemotherapy. Sativex is being developed in the UK, and it's a mixture of THC and CBD, and is being studied for treatment of MS out of UK. And it was in 2014 granted fast-track status for studies in childhood epilepsy in the US. So that is a drug that is still being studied. And then we've had Sesament, which is Nabilone, which is a cannabinoid. It is not THC. It is truly a cannabinoid that has been found to interact in much the same way that the THC does. And it's, again, used for nausea and vomiting. So my question on medical marijuana, not on these approved pharmaceutical things or pharmaceuticals that are being studied. If you're taking a medication, I'm sure you want a pharmaceutical grade. You don't want it to be something that was grown in your neighbor's garage. Now, marijuana has been available for research, and I did a quick search for marijuana through PubMed, which is a link into the National Library of Medicine. In just a few seconds, I came up with 24,000 citations that referred to marijuana that have been published over the last 30 or 40 years. And the Controlled Substances Act does allow for bona fide research. The FDA approves the study, but the DEA then establishes the requirements for the use of the marijuana, how it is to be stored, how it is to be administered, and to ensure the integrity of the entire study. But research on marijuana has been going for at least 50 years. And this is, again, Dr. El Soli, and I mentioned earlier that Dr. El Soli is the person that determines the concentration on the DEA specimens submitted. I want to point out that the DEA requires him to have 2 10-foot chain link fences. There's an 8-foot space in between. The inner one is electrified. When he's growing in this open area, he has armed guards in 4 of these guard towers. And this is in the center of Ole Miss. And I actually visited it. And he took me into his grow area, which is a concrete building with a lock that is very much like a safe in a bank. We had to go through that, and then I got to look at some of the buds on his plants. And I didn't think about it at the time, but I was headed to the airport, and I was just glad they didn't have a drug dog there in the airport, because I would have undergone some additional searches, I'm sure. But Dr. El Soli is well known for producing the marijuana that is used for the research studies in the U.S. Now, the effects of cannabis, I still have some time, right? Okay. The effects of cannabis, cognitive effects, and there's little controversy about driving impairment. There is a withdrawal, a number of people become dependent. Brain imaging studies have been done, and to show that the changes in the brain are in those areas where there's cognitive motor skill and coordinated movement involvement. And I know that there are a number of publications on memory issues and academic consequences and a variety of studies of effect. Now this, I want you to look at this. This is looking down basically on a brain. And this is an occasional marijuana user. This is a chronic marijuana user, so compare that to that. It's a PET study, and it's taking a computerized section, cross-section of the brain, and the person is given a nuclear material, and you can see the brain activity. So this is, there's very little activity going here, a lot of activity going here because of the red. That's how it shows up in the PET scan as activity in the brain. But this to me is quite interesting because it may explain some of the recent feelings about driving, where the impairment in THC driving that is not as visible as with alcohol, but there seems to be limited ability to respond to unexpected events. And so what I have heard one investigator say is that the brain is involved, busy doing other things, and so when something unexpected happens, then there's just not an opportunity to respond. The brain's too busy. I believe someone else is going to talk about cannabis hyperemesis, so I'm going to just kind of skip this one, but it's getting to be a real problem in ERs across the state. Now, sport, World Anti-Doping Agency prohibits cannabinoids, and here's a 2-man bobsled hurtling down a nice track at 80 miles an hour, and these drivers actually will sandpaper their fingers so that they are more sensitive to the controls on this bobsled. There's a good reason to not let them be impaired by marijuana. Professional sports prohibit marijuana. NCAA prohibits marijuana. Now the NFL has 2 programs, one for street drugs and one for performance-enhancing drugs. And I just comment that Aben Britton, who has been speaking out for marijuana, was suspended in 2015 and he's not played since. So I kind of question his making sound decisions concerning his career. Okay, it is a gateway drug, has a number of effects on a person's performance and later life. And I do want to get to the drug testing to say a couple of words about this. The Department of Defense started a program in 1982 following a crash on the Nimitz, killed a number of people, destroyed millions of dollars of aircraft. At that time, 50% of the E1 through E6 enlisted troops had used marijuana in the last 30 days. The current program that DoD has, it's down to just a few percent, 2 or 3 or 4%, depending on what drugs are involved. But basically, DoD cleaned up its drug abuse problem. Federal interest started, and this was for federal employees in the Department of Transportation. A couple of locomotives came together with an Amtrak train and again killed a number of people. The result was that the federal government has a program for the Nuclear Regulatory Commission, which controls all of the reactors in the country, all of the personnel and contractors and subcontractors. Department of Transportation, all modes. This means that your pilot, when you're flying somewhere, is subject to random drug testing. DoD, of course, has a program, and then federal employees that are in safety-sensitive positions are all subject to drug testing. Marinol will be detected, Sativex will be detected, THC will be detected, but CBD is not detected on a drug screen. A couple of changes that are coming in the drug testing program for DOT, and you all know that OxyContin has been a problem for the last few years. We expect that by the end of this year that synthetic opioids will be added, and OxyContin and hydrocodone and a couple of others. Then the next step will be to add oral fluid, and that's going to be a big one, and I'll show you the next slide as to why that is so important. DOT will likely follow suit with the addition of all of these drugs. I've talked to some contractors and trucking companies, various people here in Colorado. Our workforce person out of Canyon City spent 2 months looking for 3 drivers that could pass a drug test and had a CDL. Pate Construction out of Pueblo looked at 75 people to get 15 that could pass a drug test to work on a construction project. And there are various collection devices. Probably all of you know about the urine specimen. It's a urine specimen in a cup sent off to a laboratory, and you come back with the result. Now, oral fluid has a couple of different types. The Draeger is manufactured by a company from Germany, and it's up here. This is really being designed for the law enforcement because it can be used as a roadside test for impairment. It's an immunoassay, so it's not perfect. But if you get a positive result on the Draeger test, then the specimen can be sent off to a lab to be tested. And now there are also additional oral fluid types. There's a swab that is just put down in between your gum and your cheek, and it absorbs the saliva or the oral fluid as it comes out of the glands, and it is a very good type of testing. I know that there is an effort to get breath testing. There are several proposed types. THC is not volatile, and so it's going to be tough to me. When I see it, I'll believe it, that there is in fact a breathalyzer that is effective and reproducible for THC. Now this is the slide I really wanted to get to, so do I have another minute? Okay. The urine results, and this is the Quest Drug Testing Index, just published September 15th, and they've been doing this for 20 years. The urine drug test increased from 3.5% in 11 to 4% in 2015. And that's a minor increase, but every truck driver in the state of Colorado knows how to defeat a urine test. It's an intelligence test. Now when you start looking at the oral fluid results, then this is where, if you remember anything, remember this, that in oral fluid, marijuana detection increased from 6% to 7.5% in 2015, 25% relative increase. What this means is that 1 out of 12 people that were given warning to show up for a drug test, many of these are pre-employment, have used marijuana probably within the last 24 hours. And so this is, this is absolutely tremendous to me in terms of impact. Oral fluid is not subject to defeat like the urine testing, but to have 1 out of 12 workers that are pre-employment that can stay off marijuana for 24 hours is a major concern. Thank you for your interest. Thank you for your time. And I've got to show you the last one here. I will not give wordy evidence to the fact that I'm done. Thank you.